Welcome to Business Authority Radio, bringing you insights from today's thought leaders, professionals, and influencers. With your hosts, Neil Howe and Craig Williams.
Hello and welcome to the show. This is your host, Neil Howe, and today my guest is Luke Ferdinands. We are talking about physical therapy again, and Luke is a physical therapist. He is the owner of Post Physical Therapy in Brookline in the Boston area. Welcome to the show, Luke.
Thank you very much for having me, Neil.
Well, tell me a little bit about yourself and how you got involved in physical therapy.
I am originally from a country called New Zealand, now living in Massachusetts. My physical therapy story, I was actually rehabbing from an injury myself, and my uncle was rehabbing from a Achilles that he had torn playing basketball against me. He was a physical therapist in New Zealand, and he was working with a number of different sports teams down there. And we got to talking as both of us were rehabbing from our injuries. I'd always had a keen interest or pursuit in sports, and something that piqued my interest in terms of how the body recovered, rehabilitated. And so through school, I kind of started to shape some of my education towards that, and eventually ended up at university studying physical therapy, or physiotherapy as it's called in New Zealand, and pursued that. And so I kind of worked initially for some professional sports teams, and then moved more into private practice, which treats a variety of conditions from neurological to musculoskeletal to some cardiorespiratory, and focused a little bit more on the musculoskeletal components of physical therapy and rehabilitation of acute injuries, of musculoskeletal injuries, of post-op injuries. And that's where I've been for the last 13 years, I think now.
Excellent. Well, tell me exactly what physical therapy is, because everybody has a different definition, and I like to get that out of you. So tell me, what is physical therapy?
Yeah, so there's some really varied parts to our profession. It can be everything from ergonomic assessments to restorative, rehabilitative type things. There's been a big shift in the last number of years in physical therapy to move away from electrotherapeutic devices in the facet that I'm in, which is musculoskeletal physical therapy, which is basically like injuries or some kind of body dysfunction that you have been injured by. Those injuries can accumulate over time, or they can be one big injury, such as twisting your ankle. And there's different scales of that, obviously. So we look at restoring people's function. You'll hear that as kind of a key word in our industry these days. And function is you being able to perform the things that you would do in daily life. Sit, squat, push, pull, lunge, walking up and down stairs. All of those are functional activities that we're always trying to help people or our patients get back towards performing at the level that they were prior to the injury.
So it's all about recovery, basically, and keeping that range of motion and the movement, and getting back to where we were before injury. So tell me a little bit about what you specialize in. You specialize in working with sports teams and athletes, it sounds like?
So we have a couple of clinics around the Boston region that we work with a fairly diverse population, people as young as 3 or 4 years old and people into their 90s. So we tend to work with people who have been injured in some way. And each of our therapists at our clinics have different areas of specialty. Mine tend to be a little bit more focused on some of the lower limb, although I will treat other things as well. Knees, plantar fasciitis, Achilles tendonitis, tendinosis. Those are the things that I tend to focus on a little bit more through some of my patient caseload.
So those are the actual injuries or conditions that people have. What brings these kinds of things about?
So it's really interesting. The knees, for example, is one of the biggest Biggest sources of injuries in the US. I think it's almost up there with lower back type injuries. And knee complaints can be either micro trauma, which is repeated stresses over a period of time, or macro trauma, which is one large stress. So you can't actually put any injury down to one repeated mechanism that will happen every single time. Sometimes it can be a movement which you're overstressing or overloading the tissue, and sometimes it's a movement where you're accumulating load, as I mentioned just before. The injuries that we tend to see, we try and correct the pain and the dysfunction first off, and then we try and move in towards restoring the function and identifying the holistic form of treatment, which is basically how this injury occurred in the first place. So if there were to be some kind of hip dysfunction that leads to a patient having knee pain or discomfort, we try and take that knee pain discomfort away initially, and then we try and move as to the root cause of the issue and why they're having those symptoms.
So I've got a knee specialist here, and I'm give you a little bit about my background. Luke, I was a soccer player from Scotland. I came over to the States and played soccer at Georgia State University here, and I was very familiar with the physical therapists and the people in the rehab room. Unfortunately, I had a couple of ACL tears. What can or should I have been doing to prevent such an injury as that?
So the information on anterior cruciate tears in terms of rehabilitation and prehabilitation, the majority of the research coming out these days is saying that your muscle on the inside of your leg, your inner quad, it's that teardrop muscle on the inside of your leg. It's called your vastus medialis obliquus. That is the key to stabilizing the knee. If that muscle fires fast, you have a good stable knee. That muscle can fire slowly, and then you will have an unstable knee. So a lot of people try and make that big muscle really, really big. Doesn't matter if it's super big, it has to fire super fast. And if that does, when your heel hits the ground and that load goes into your knee will be stable. If there's a lag of a short period of time, the load goes into your knee, and then the structures inside your knee will be challenged. ACLs like you had generally result from some form of twisting. In the young female population, a lot of this, the predisposition that young women have towards ACL tears comes from potentially weak hips, and that then places a torsional or twisting force on the knees. But if you were looking at somebody in your case who you had a couple of ACL tears, is that correct?
Right.
You're looking at the rehab after the first one as being vital to reducing the second one. There was some some research came out of New Zealand a number of years ago that showed post ACL tears, that muscle on the inside of your leg shuts down. And so it shuts down on both sides, not just the side that was affected. And we used to think that the opposite side or the contralateral side would increase in strength. But now we know that there's a bit of a decrease that happens in your side that is not affected post-surgery and post-injury. So post-surgery, you have to go through and make sure that that inside part of your quad is firing fast, firing strong. If that happens, you have a decreased chance of osteoarthritic change, and you also have decreased pain discomfort, which will decrease the inhibition or the lack of control that muscle has. If you have pain in your knee, that muscle on the inside of your knee shuts off as well. So it's kind of a double-edged sword. You need to make the knee strong, but the key is to making sure that muscle on the inside of your leg fires very fast.
Okay. I did have a lot of atrophy in that leg, but through the rehab, it definitely got stronger and stronger, and I felt it was relatively strong as far as pushing weight. But I guess the problem, or this is the first that I've heard about this, was the fact that it wasn't firing fast enough. Explain what that means. So
you've got your generic quadriceps. your VMO, which is your vastus medialis obliquus, is on the inside of your leg, and it functions at 0 to 30 degrees. So a lot of movement is initiated through the knee at 0 to 30 degrees. So if you think about you playing soccer, and you are going to accelerate and turn, your knee needs to be stable in that 0 to 30 degrees, and that's where your VMO fires. Where a lot of rehab focuses on is 0 to 90 degrees, or pushing big, strong weights, doing leg extensions, doing leg presses. You're reinforcing the quadriceps as a whole, but you're not isolating the component, which is potentially going to lead to knee instability, which is the firing of that inside part of the leg. So you've got big, strong muscles, 4 of them, that all work together and all work very, very strong. They work in unison and they work well. But if you don't isolate and then train towards getting that inside part of your quad to work with all of the other muscles, you won't necessarily have the best progression or follow-up at 2, 3, 5, 10 years. And I often tell people or patients that I see, we don't care about your knee right now. We care about you in a year's time. We care about you in 2 years' time. We want to decrease the chance of recurrence of injury, which is re-tearing, but also there's a huge amount of osteoarthritis that forms in patients with ACL reconstructions that have been done historically, because that firing on the inside of the leg is not happening properly.
So as a physical therapist, what would be the solution? Maybe if you can tell me twice, at the time of injury, the recovery, and we're talking 20 years later, where, it's still not as good as it could have been.
Okay, so even now you can still create a change in that knee if you identify the root causes. So in our clinic, we would bring you in. This is you now, and then I'll get back to you then. So we would bring you into the clinic, and we would put you through a series of different walking tests. We would identify where you were weak and where you were not stabilizing, and then we would identify that joint being placed through both extension and compressive force. Quite often, people who have had reconstructions similar to yourselves don't really like getting into the end range of a squat. Now, if you take any joint or any muscle and you associate it with pain, that muscle will not fire as well as you can. And here's an analogy that I give quite often. Take a 5-pound weight and hold it out straight with your arm, and you're good, you're strong. Put that down by your side. Somebody comes up and punches you in the shoulder. That is a pain stimulus. Try and lift that weight up, you can't do it anymore. So you are not weak, it's simply that pain has caused inhibition to that muscle. And if pain causes inhibition to that muscle, the muscle switches off. The beauty of your normal shoulder is that pain stimulus, where somebody's punched you in the arm, goes away very quickly, and in 5 minutes you can give it a rub and lift it up again. The same thing is happening in an ankle, in a knee, in a hip, in any joint that is having pain associated with it. So if you're trying to strengthen a joint that has pain, you need to get rid of that pain first, because the muscles will not engage to their full capacity if you are trying to strengthen associated with pain. That can also be said sometimes for swelling, for grinding in the joint, and that's where we would use something called manual therapy, which is hands-on techniques. Those are taught in the majority of schools these days. And so we try and change the mechanics of your joint, or change the mechanics of your tissue, so that pain is not associated with it, and so that you can recruit through those muscles. So that's what we would potentially do for you now. For you back then, there's a little bit of controversy about some of the icing these days. Some people are for it, some people against it. We know that compression works, but getting the fluid out of that region as quickly as possible will delay the reduction of that inside muscle working. So if you get rid of the fluid, the inside muscle on your leg will work quicker. But we need to retrain that specific muscle and then combine it with other tasks where it's working with the hip, where it's working with the ankle, and where it's working with the rest of the quads, to make sure that it not only works on its own, but it works in unison with that entire chain.
So what kind of exercises should I be doing to strengthen that area? You mentioned 30% as opposed to 90% angle? Explain that.
So if you imagine when your leg is straight, that's at 0 degrees. When you're bending your leg a fraction, it increases degrees. If your knees are sitting at right angles, that's 90 degrees in your knees, 90 degrees of what we call flexion. So from your leg fully straight and then bending it down to 30 degrees, that's where you want to try and train that muscle to work. That's where you get your targeted response to the VMO, or the muscle on the inside of the leg. So each knee is quite complex, but it's also quite simple. It's just depending on the predisposing factors that you've got. But if you had just atrophy to the inside of your leg where you were trying to get that muscle to fire, we would get you standing, doing some small knee bends, so bending your knee down to 30 degrees and coming back up and focusing on your knee and your hip, making sure that your knee doesn't track in towards your opposite knee and making sure your hip doesn't push out away from the other knee. So that would be key. And the reason that we do that when you're standing is because you create more awareness at a joint when there is a compressive load. It's called a closed chain exercise. You create more awareness at that joint when you have your foot on the ground rather than having your foot off the ground. We would get you doing a series of different exercises to make sure that you were stable from the hip. But again, all of that is post making sure that your knee is moving properly, making sure that you have full range, and that also you have good function, because we can try and push that strengthening as hard as we want. But if there is any predisposing factors which is going to cause you pain or restriction of movement, the knee will not fire. So you can strengthen it as much as you want, but you are not going to get ahead of where that strengthening is or needs to be.
Okay. All right. Well, let's now that I've got myself sorted out, let's get into some of the misconceptions that people might have about the physical therapy industry. What are people's views on what a physical therapist does?
So this is where there's a few clinics around that try and differentiate themselves, and we're one of them. We work one-on-one with our patients. Our therapists are all licensed, and they work directly with the patient. We don't use aides or assistants or exercise technicians at all. So in the 80s and 90s, even though they were great decades, physical therapy had a predisposition towards just using electrotherapeutic devices, ultrasound, infrared, heat packs, ice packs, stim. Research came out and it wasn't as beneficial when compared with manual therapy. So mobilization of joints, mobilization of soft tissue and massage. And so we have really trended towards making sure that when a patient comes in, whether it be an acute or a chronic issue, that we identify that issue. Say you can only lift your arm up to 90 degrees out in front of you. That would be your issue. We then implement some strategies, whether it be joint mobilization or massage or whatever, and we try and improve that range of motion. And with our patients, we try and show them a clear change with what we are doing within that first session. Can't do that with everyone, but we try and show pretty much everybody that they can improve with physical therapy. So physical therapy a long time ago used to be passive. You would turn up, lie on the table, maybe do a couple of exercises and not see any form of progression. Where it is now is trying to be taken forward so that you can see that you are improving session by session by session. So
that definitely is a big difference from what it used to be, rather than just sitting on a table with an ice pack or, some machine working on you. You're actually getting one-on-one time with the physical therapist, which is a lot better for sure. Now, what fears might somebody have about going to see a physical therapist? If they have an injury or a chronic issue, what fear might stop them from actually picking up the phone and calling you?
When anybody is in pain, their body is already in a stressed state. So if you're in a stressed state and you're hyper aware or hypersensitive, you might be quite concerned that the physical therapist is going to cause you some pain and or discomfort. if you take a restriction like we were talking about before with the shoulder, where somebody can only lift their arm up to 90 degrees, you see a lot of patients who, for a long period of time, they've gone on for 1, 2, maybe 3 years, and they haven't worked on that range of motion. But then there'll be some form of catalyst that happens in their life where they can't put a shirt on one day or something along those lines. They will call us and say, I want to come in for therapy. You see them, and they've been apprehensive and not come in because they thought that the physical therapy would cause them pain. But they've been in pain, which has been stopping them getting their arm above 90 degrees for a long period of time. If you're working with a licensed physical therapist, that physical therapist may cause you some discomfort whilst working on you, but pain is not necessarily a precursor to everything that we do. And so the apprehension that some people have about physical therapy always being painful is a little bit misguided. Again, sometimes some conditions require a little bit of discomfort, but if we show you afterwards that discomfort has improved your range of motion, improved your strength, improved some function like a squat or reaching behind your back if it were to be a shoulder or whatever else, then you can justify that the means may justify the end.
So it's something that they really have to do in order to get better. It's not going to get better on its own, and they have to, have that help to get through that range of motion and maybe get through that little bit of pain in order to see the results in the end.
Correct. And so a lot of things will heal naturally. But what we're trying to do is we're taking the ones that are a little bit more complex, the ones that aren't healing as fast as they should be, the ones that aren't healing on their own at all because the tissue has sustained too much load or the joint has sustained too much trauma. And we're trying to restore all of the things that previously were there. So rehab, as you kind of mentioned before, lying on a table used to be quite passive. Now it's a lot more active. You will be incorporated with some of your exercise that we give you, but we're also working towards goals that ideally you will set. And so the patient is involved a lot more in their physical therapy rather than just being a passenger, if you will, going in, lying on a table, walking out, and not knowing if they're any better than they were prior to the appointment.
So how long can a physical therapist start making a difference in somebody's life? How many sessions does it take?
It's really dependent on the condition, but if you're not seeing a change after working with your therapist for 2 or 3 sessions, you should potentially be asking the physical therapist why you're not seeing a change. And so you have to identify something that you can change, and from there work towards that common goal. Because ultimately the therapist is not serving you, and you're not serving the therapist if you're not improving in terms of your symptoms. But if there is a component that is not going to change over a period of time, and it may take 3 or 4 weeks to create a change, you should be made aware of that within the first session.
So just setting expectations, basically.
Yeah, but also there needs to be some kind of objective goals that you're both working to, rather than just saying you're going to come in for physical therapy 2 times a week for the next 4 to 6 weeks. That doesn't really wash anymore. You need to work towards a common goal that the patient and you have both established, so that you can show that patient that their time and interest and their vested interest in themselves is worth it.
So in all the patients that you've seen over the years, there's probably 1 or 2 that spring to mind that you've really been able to help and make a dramatic change in their life and increase their movement and increase their way of life and what they're able to do and get back to, the things that they were once able to do. Give me an example of somebody that springs to mind that you were able to help like that.
So something that happened in the last few months, we had a patient who rolled in maybe 7 or 8 months ago, and she had chronic plantar fasciitis, which is pain in your heel. Sub 30-year-old, so let's say around 28. Woke up in the morning, over a period of time it got worse and worse and worse, and when she'd wake up every morning, couldn't put any weight on her right foot. couldn't bear any weight on her heel during the course of the day. Now, she previously was a very fit, very healthy, very active mid-20-year-old, but she'd been shut down for almost 2 years, I believe. And she'd been and seen all the doctors in the land, had cortisone shots, had physical therapy a couple of different times, and they'd worked on her with an ultrasound machine. She hadn't been getting any better. So when she turns up to see me, who she's been referred to by some podiatrist, she's obviously slightly disgruntled, and understandably, she doesn't necessarily believe the things that I say when I say we're going to work towards this. So we try and get her to walk on her heels, and she just can't do it. And it looks like an excessively kind of dramatic response, but it's massively painful because she has this huge lumpy tissue that's in the base of her heel. We get her onto the table and do some aggressive mobilization of what's going on in her heel. And I, after 10 minutes, ask her to stand up and walk again on her heels, and she can bear the tiniest bit of weight going through her extremity. She hasn't been able to do that for a very, very long period of time. A smile kind of creeps across her face, and she's like, okay, cool, I might buy into this. I then couple that with some exercise which is going to restore the facilitation of new tendon growth. And over the course of the next 6-7 months, we work towards our goal, which is walking pain-free, getting out of bed in the morning pain-free, and then ultimately progressing towards running. Now she's back in the gym. She's running on different surfaces, absolutely ecstatic, which is great. That's a real success story. And that's essentially why we are in the profession. But if you don't get to the root cause, which is the degeneration of her tendon, and you're just treating the symptoms, which is we're going to throw another cortisone in there, it wasn't helping her. So she needed more. And then we have to look at the biomechanics through her foot, ankle, knee, and hip to make sure that it doesn't come back or happen again.
So physical therapists really do look at that root cause. Why do you think I don't know if it's most people, but why do you think people don't think to go to a physical therapist first? Why are they going to see other people?
Well, that's a very good question, Neil. But basically, like, we live in a society where things come to us really, really quickly, right? And so sometimes people will go the route of taking the pain away with drugs, like an anti-inflammatory or a steroid, and not necessarily addressing the root issue, because that medication can reduce the pain or discomfort. And so they'll just continue on that course of drugs, trying to alleviate some of the pain that people are having. They may go for a surgical route, which is quite a quick response. But as you're aware, sometimes the surgery has factors thereafter which can be not crippling but life-altering in terms of not having the correct biomechanics and maybe having some atrophy afterwards. Physical therapy may take a fraction longer than some of the other interventions that you may find out there, but we are essentially looking to keep your tissue normal. We are not looking to cut anything out, and we are looking to make sure that you can restore all of your function. Sometimes that can't be done, and surgery is required. Physical therapy can't help every single patient, but even post-surgery, we want to make sure that rehabilitation is safe, it's effective, and you get back to your full level of function that you had prior to that surgery, if it possibly can be attained.
Very good. Last question here for you. What is the one thing that you would recommend people would do to prevent injuries or to relieve the chronic pain that they're suffering with on a daily basis?
In terms of preventing injuries, there are a number of things that you can do. If you're training for a sport, if you're training for a hobby, if you're just even in life, progressive load is really, really important. And I'm sure if there was a football on a pitch and one of your friends said, come around and let's play a game against each other, you'd probably think that you were back in your heyday and that you were able to drive that ball from the halfway line all the way into the goal. But obviously that's not too realistic as you age and as you kind of decondition to various things. So progressive load is really, really important. Post-injury, or if you have an injury, go and see a physical therapist. They can take a look at you and see if you're predisposed to any kind of injuries. They can also have a quick look at you and tell you if physical therapy is going to be applicable in that particular case. Again, not every single case requires physical therapy, but very often it can help you.
Excellent. Well, we've been listening to Luke Ferdinands. He's the owner of Post Physical Therapy in Brookline, in the Boston area. Luke, what's the best contact information if people want to get in touch with you to answer some of their problems or to come in and see you?
Sure. If anybody's wanting to get a hold of me, they can email the clinic, and it is info @postpt.com. Our website is www.postpt.com. And you can see all of our staff and links to their bios. And so if you have any kind of complaint or injury, you can look up what they do, who they are, and who you think would be best served to help you in that particular scenario.
Excellent. Well, we've got a lot of information here from Luke today. I certainly got a lot of information for my specific need, and I know we could have talked about many more specific needs in depth. But thank you very much, Luke, for being my guest on Business Authority Radio today.
Thank you very much for having me, Neil. Really appreciate it.
And to our listening audience, if you like what you hear, hit that like button, share, and we'll see you next time on the show.
You've been listening to Business Authority Radio with Neil Howe and Greg Williams. To learn more about the resources mentioned in today's show or to listen to past episodes, visit businessauthorityradio.com.